Good morning, everyone, and welcome to today's webinar hosted by PYA, 2023 Medicare Physician Fee Schedule Proposed Rule, Part 2. PYA is happy to present today's webinar on this important topic. You will have the opportunity to submit questions to today's presenter by typing a message into the question pane of the control panel. We'll collect these and address them by email after the webinar. All of our webinars are recorded and released with a copy of the slides after the event. With that, I would like to introduce Valerie Rock, Consulting Principal at PYA.
Thank you, Laura. Thank you for all of you attending today live, and thank you for any of you listening to this later on during the week or in the next coming weeks. Really want to encourage all of you to listen intently to every detail here, because it's clear that you guys are excited about this information coming out and concerned about this information coming out, as I am. And really, this is a call to action. While we're learning what we need to learn about the fee schedule and what it's saying and what is being proposed, it's also important to comment and make sure that you're getting your voices heard as we go through the comment period, which is open until September 7th, because your voices matter in these cases where we're seeing reductions and maybe things that don't even make sense. And so we're going to talk through a lot of that today, but feel free after or during this session to send us questions, via the chat, via email, and let us know what your thoughts are and your questions are, because we want to make sure that we're communicating everything across properly, and also to make sure that that everything is clear on what is being stated, at least to date, so that we can go into the final rule with everybody's comments, on board, and everybody's considerations in play. CMS can only see so much of what's going on in the industry, and they have certain people that may comment in, but if they don't hear across the board, then they don't know your situation. So it is really important to get your voices heard. I don't think there's enough soap or soapboxes for me to stand on today, because I have a little bit of a soapbox to stand on today, but hear me out and hear what my thoughts are, and then let me know what you are thinking and what your concerns are and what really is implicating your situation, and let's work together as a community to get this communicated across. So today specifically, of course, this is part of a 3-part series. I'm only dealing with a subpart of all of the considerations for the Medicare Physician Fee Schedule. I'll be going over E&M services, split shared visits, practice expense calculations. I'm also going to include the MEI, the Medicare Economic Index, behavioral health services, and then the request for information for the global surgical package and the dental and oral health services. And then I have a list of links at the end for you to consider and review on your own as well. So I'm Valerie Rock. I'm a principal with PYA. I've been with the firm almost 19 years now, and I oversee our revenue integrity services, which focus on all areas of physician to hospital, post-acute coding and compliance related services. So I've been, really entrenched in the E&M guidelines over my career. And so a lot of these changes that are occurring are very significant to my work and how we view things. And so that's a little bit of why you hear the passion behind my voice today. So we'll start again with E&M services. As I was reading through the E&M guidelines expectations, as CMS is implementing the 2023 guidelines that we have now released from the AMA, I saw it almost as a chart. So I'm providing you a chart via these slides so that you can print these out and view these across, what is CPT saying, what is CMS saying, and what is the valuation associated with that. So I think that will at least maybe help you as it's helping me to digest this information. So we'll start as a reminder. We have changed our guidelines from 1995 and 1997 E&M guidelines. The AMA submitted and CMS approved the 2021 E&M guidelines for the office and other outpatient services. So those were the only changes from 21 to 22. So now in 2023, that's when we start seeing those facility code changes. But remember that while you can look at CPT and the AMA for those CPT guidelines, the CMS policies associated with these codes are in the Medicare Claims Processing Manual, the Medicare Benefit Policy Manual, and then you also want to go to your MAC, your Medicare Administrative Contractor, to see what they're saying about the E&M guidelines as well. So continue to watch that because we're still in an implementation phase regarding these 2021 guidelines related to the office-based codes. In 2021, we had a significant increase in work RVUs for those specific codes. You'll see that there's also been some shifts in work RVUs for the facility codes, and we'll walk through those. A lot of the shift in 2021 is still being felt today because we have kind of kicked the ball down the road because of COVID and because we didn't want to have a huge negative shift during the middle of COVID. But you could argue that we're still under a PHE, the public health emergency, and we're still in the middle in the throes of, COVID. So a negative 4.4% adjustment on the conversion factor is going to be a significant hit to our practices, our providers. So it's important to communicate that upline to CMS and to your specialty societies. So in general, when we look at all of the E&M guideline changes as it relates to the 2023 proposed rule, CMS is adopting the CPT guideline change that says a continuous service that spans the transition of 2 calendar dates is a single service and reported on one date, which is the date the encounter begins. So again, you have a continuous service over a midnight. And as long as that's a continuous service, you would bill on the initial date of that service. Now, one thing that CPT has acknowledged and CMS does not acknowledge is subspecialties. This is important when we start talking about initial inpatient and initial nursing facility coding, because you have to determine if you're dealing with CPT guidelines, which maybe a commercial payer is dealing with, or if you're dealing with Medicare. And you'll deal with that differently if you're dealing with a subspecialty. Otherwise, determine that based on the specialty level. Now, what you'll see from a valuation perspective is that the work RVU adjustments for these other or facility E&M codes range from a negative 48% on the 99281 to a positive 32% on the 99316 and 99231. Now, that negative 48% is a significant change because that 99281 is now being shifted to be a nurse visit. And that's why you see that significant negative change. We'll talk about that when we get into the ED services. But generally, they're not, switching and ranging in that level to a negative. But we'll walk through those other codes that are increasing as much as that 32% and show you kind of where that landed. But what you'll see overall, so if we take the entire impact of the Medicare physician fee schedule across all specialties, not just including E&M, but all changes to the work RVUs and all changes to RVUs in general, we see a kind of a range of negative 4% to up to 5% of a shift, depending on the specialty. So this is not as big of a shift as we saw in this phase of the proposed rule in 2021, where we were seeing negative swings up to 11% and 14%, and positive swings in the equal and opposite direction. So there's a little bit of a narrowing of a shift, but it's still impactful. So you'll want to see how your specialty lies. So you can see that in the Medicare physician fee schedule. In regards to hospital inpatient codes only, CMS did adopt the 2023 guidelines that were submitted by the AMA recently. In the past month or two, we've had a release of the 2023 E&M guidelines for facility coding. So now we have a 2021-2023 guideline for all E&M services. So now we've kind of captured all the rest of those services, and CMS is saying, yes, we acknowledge these guidelines. So now that we have a change to the descriptions, we have a change to where we're coding based on medical decision-making only. When you're looking at the level of service, there are requirements under medical decision-making. There's three kind of components that we're looking for, and we have to meet 2 of 3 of those components in order to get the level of medical decision-making. Or we can use time. Time is now defined differently than it was in 1995 and 1997 guidelines, and so you'll want to know specifically what those time requirements are. So you can use time or medical decision making, though we have heard from the CMS contractors that generally you would expect that the medical decision making would be the predominant way that you would select the code, that time would not be the predominant way you select a code. And if you look at the times on these codes, it's really more beneficial to use medical decision making. Now, CPT did revise the inpatient codes to include observation codes. So the observation codes have actually been deleted, and we'll talk about that in the next slide. So now we've got a combined category of service, hospital and observation, all in one. CMS has clarified on their end that they're bundling the outpatient E&M into the inpatient service on the same day. So if you have an outpatient E&M service and an inpatient E&M service on the same day, those would be considered bundled. But they will allow you to bill the OBS or inpatient on the following day, even if less than 24 hours from the office visit. Whereas CPT is allowing those to be billed on the same day. For swing beds, you would bill the hospital or nursing facility based on the place of service. And then if you transition from observation status to inpatient status, that does not constitute a new stay. In regards to discharge services, we can only bill a discharge service for those providers that are responsible for discharge. If the provider is not responsible for discharge, you would bill the subsequent hospital codes. So when we look at the CMS valuation under the proposed rule, you can see that there is a negative 15% and negative 9% change on the initial hospital care codes level 1 and level 3. But there is no change to the 99222. Now, generally, majority of the services billed by providers for that initial hospital care would be lumped into the 222. And they often are trying to mitigate the billing of the 223. So because of that, you see kind of that shift in the payment. However, a majority of the codes that we're billing are subsequent hospital care codes because, we're going to see the patient continuously through their stay. You see a shift up from 14% to 32%. So that is a plus that we're seeing even in the midst of this negative 4.4% conversion factor shift. So similarly with the inpatient codes, now we have the inpatient codes and the observation codes bundled together. CMS has adopted the guideline changes for these codes, and so they're acknowledging these combined codes. Again, They're bundling that outpatient to observation on the same date, but they will allow that visit to be billed on the second day. But they are maintaining their 8 to 24-hour rule. Observation had its own rules, and what, the requirement for billing certain services based on this 8 to 24-hour rule. So they are maintaining that. So when you're billing these codes for observation purposes, you want to follow the under 8 hours, 8 to 24 hours, or 24-hour requirements. The work RVUs are similar. The transition, because the values were pretty close together with the initial inpatient codes, the changes are very similar. So you'll see that negative shift on the level 1 and 3. On the initial inpatient, you'll see a positive shift, same positive shift, 14 to 32% on those subsequent observation services, which will now be billed as inpatient observation codes. But it was, I did a comparison of the original observations, like this year's codes to next year's codes, and found that to still be true. In regards to the ED services, so again, CMS adopted the 2023 guidelines, 2023 codes. They will continue to allow ED and critical care to be billed on the same day. The ED visits, because we're moving to this new medical decision making, the level 1 doesn't have a level of risk. And so now it is a nurse visit. So instead of deleting the 99281, it is considered a nurse visit in the ED. Then you move to straightforward, low, moderate, and high, depending on the level that you're billing, the 99282, 99283, 99284, 99285. So straightforward, low, moderate, high is your risk. And then we also have, the number of diagnoses and things like that that you're dealing with. The CMS clarifies that the documentation in regards to a visit where you have an ED service and critical care service in the same day, that those need to be unique services, and that ED service occurred prior to the critical care service. So it wouldn't be the inverse. You would have to have the ED service documented very clearly, and then that critical care service documented very clearly. And of course, critical care services are truly based on time, and so you would have that time documented uniquely for critical care. There are some scenarios that they're clarifying as well. So if an ED physician requests a patient's physician to come in and determine if the patient should be admitted, they should bill the hospital, initial hospital care code. The ED physician should bill the ED code. Then again, they're not dropping the policy on the same day critical care and ED visit. In regards to valuation, the RUC committee, the Relative Value Update Committee, recommended a reduction to the 99284, but CMS decided to maintain that value. So they're maintaining the values for each of the services from level 2 up, and again, reducing that 99281. In regards to the skilled nursing facility and nursing facility visits, again, we have the shift in the new guidelines. Everybody is acknowledging, CMS is acknowledging the 2023 guidelines for the nursing facility visits as well. Your non-physician practitioners can perform an initial or subsequent nursing facility visit prior to the federally mandated visit by the physician. And if a patient is admitted to the skilled nursing facility and initial nursing facility assessment performed and then transferred to nursing facility, it's not a new patient stay. So it's appropriate to assign, so it's not appropriate to assign an initial nursing facility code after the transition. In regards to CMS policy, an office visit or ED visit on the same day as a nursing facility initial assessment cannot be billed together. So again, that bundling of an office visit or an ED visit on the same day as an initial nursing facility visit. Again, the swing beds would be billed based on the place of service. And then again, as CMS has stated that it does not recognize subspecialties, you would be billing an initial visit only if there's a difference in specialty, not if there's a difference in subspecialty and they're in the same specialty. In regards to the valuation, the RUC valuation for the nursing facility codes are being questioned for that top initial and subsequent code because of the same 45-minute descriptor. So there's a difference in the valuation, but there is the same 45 minutes. So they're questioning that. So that might change as we move to the final rule. And then CMS has asked the community, so this is something you may want to communicate in comments back to CMS prior to September 7th, if you will be impacted by the deletion of the 99318. So there was a deletion of the 99318 for that initial assessment visit. The expectation is that we would be billing the 99309 generally for that service. And so, that is a 1.92 versus the 1.71 of the current code. So, that's a potential shift up instead of down. So perhaps you actually have an increase in value for that service, and would you anticipate otherwise being negatively impacted? So communicate if you do believe so. In regards to the home or residence services, what you'll see is that CPT has deleted the domiciliary, rest home, and custodial care services and lumped them all together with the home and residence services codes. So now we have a new combined set of codes with all of these code ranges, and they're based on medical decision making or time, just as the 2023-2021 guidelines all together state. There is a deletion of the home visit code 99343 because it has the same medical decision making level as the 99344, so they're reducing that. This code set does not have any further refinements within the Medicare physician fee schedule from CMS, so that's good. And then you can see here that the CMS evaluation depends on the code. So I would do an assessment on how you're generally coding as a crosswalk, perhaps, to these new codes, and see, based on the level, based on the medical decision-making level or risk level that you're generally coding, that, how would you be seeing, would you see a negative shift or a positive shift in your reimbursement? Prolonged services. Now this is a dicey one. What you'll see here is that CPT has deleted 99356 and 99357 and replaced it with 993XO. Now that's a placeholder code. We'll get that released, soon in regards to what that specific code is. But it's for the prolonged inpatient OBS E&M each 15 minutes, with or without direct patient contact. And it's based on the descriptor time. So when you're looking at the specific codes that you are billing these prolonged services with, you would use the descriptor time. So within CPT, you have a time published. You would use that published time as adding to 15 minutes so that you can then get to the amount of prolonged service that you have and bill for each of those 15 minutes. CMS has stated, we don't agree with the way that the time is being interpreted here. We think that the descriptor time is not really full time because it's really intra-service time or face-to-face time, and so therefore we think that that's not the total time. So we want you to use our G codes, which they're going to create. Right now they're placeholder codes GXXX1 through GXXX3, depending on the place of service for the 3 types of services. And we want you to use the top level of code take the physician time file within the Medicare physician fee schedule, determine the total time for that code, and then you cannot bill a unit of this prolonged service code until you meet 15 minutes. Now, I don't know about you, but I don't know many people that can locate the fee schedule, the work RVUs, let alone the physician time within the Medicare physician, within the Medicare website. I think this is ripe for problems because many people don't know where this is. You would have to create a very specific log of the time, separate from CPT. So you'd have to determine the payer you're dealing with. You'd have to deal with all of the aspects to come up with how much of the prolonged service you can bill. My guess is that most practices would just start billing this 993XO, whatever it ends up being, code, get a denial from Medicare, and then they'll say, well, we're just not getting paid for prolonged service codes, and then they won't know about the G code. Or they'll start billing the G code, but use the descriptor time because that's been historically the way you do it, and they will be overbilling. So we're creating a real big problem with this shift and change. So I encourage you to communicate to CMS that this bifurcation of this is going to create compliance issues inadvertently, and that people will be going outside of the bounds of this pretty quickly if they're billing prolonged service, which would be, appropriate to do when you're spending more time. So let's make this more simple and get these valuations to where it makes sense, even if it means that CMS brings a lower value to it because they think that the time, is essentially different than what the total time is. So we've got to come to an agreement somewhere and make this more simple because this is very ripe for compliance concerns. Put this on your work plan if they implement this as is, because this will be an issue. In regards to critical care, this is mostly a reminder, and they did make a refinement or a clarification on a technical error that they had in the previous guidelines. So in the 2022 Medicare physician fee schedule, we had a shift to shared visits, a shared visit change. So we have the 2021 guideline changes that impacted critical care. Then the critical care guidelines were basically removed in 2022. We got the shared visit requirements, and now we know how to bill for APPs or NPPs and physicians, depending on how we're stacking them, if it's a shared visit or just a group of physicians. Let me know if you have any questions on that, because there's a lot of confusion around those guidelines as well. But in the 2022 Medicare physician fee schedule, there was one section that stated that you were required to meet 104 minutes in order to get the 99292. But in another section, it said you had to meet 75 minutes, which is more of like a CPT rule. They said, wait, we meant 104 minutes. So they want you to get the full 30 minutes of the 99292 in order to bill the 292 instead of the halfway point. Now, what I'll state about this is that, and we've seen it since this kind of evolution to this 104 minutes, is that there's a misunderstanding on why CPT added the range of time in general. When CPT added the range of time, the intent was to get to the halfway point of the next code. The 99291 was always a 1-hour code. The 99292 was always a 30-minute code. The purpose of 75 minutes was to get to the halfway point of the next code so that you could then bill the 99292. Using a concept of getting to 104 minutes to meet the 99292 means you have to exceed 1 hour and 30 minutes by 14 minutes. and that does not make sense. So I think we need to ask CMS to revisit that and reconsider that, because that was not the intent and was not ever, I don't think they ever changed the valuation for more than an hour and 30 minutes. So I think it's really time for them to revisit that, because I think a historical context has been lost on why we got here, and so we need to revisit that. The split shared visit rule requirements to get to a 50% time, in time for critical care by the NPP or the physician, and billing under the NPP if that is more than 51%, is causing the services that are shared to be generally billed under the APP, because the physicians and APPs are in the critical care unit. They're building up time. The physician comes in the morning, maybe in the afternoon, and the way that they're seeing the patient is different than the APP. And so the expectation is that a lot of those services would now be billed under the APP, and that is creating some issues with the way that people are looking at how they're going to structure their entities, how they're going to pay for their APPs or NPPs. They're looking at, how are we going to compensate physicians if their services are basically hidden under the APP. So it is really important to analyze that and communicate the impact of these critical care changes. Even though we only have a slight revision on these critical care services, in the split shared, we'll talk about here just in a second, it's time to communicate the impact for critical care, because there is a huge shift. There is a huge concern, and I don't see that concern is being communicated as much as it needs to be yet. So split shared visits, my other soapbox. So we have a partial delay for these split shared visit rules. If you're not familiar, CMS last year, again, said that we want, in order for a physician to bill for a service that is also performed by an NPP, I'm going to call it the person an NPP, because in the Medicare physician fee schedule, in order to find these rules, you would have to look up non-physician practitioner, because advanced practice practitioner is not in the Medicare requirements. So a physician and an NPP see a patient on the same day in a facility where incident 2 is not allowed. How do we bill for that? So CMS has said, we will allow you in 2022 to bill based on one of the key components being fully met by the physician. Then you can bill under the physician for the level of service that the physician meets. Or you can bill based on the person that meets more than 50% of the time as defined by CMS within the Medicare physician fee schedule, which actually mirrors the office outpatient time definitions. Just note that. Now, this is an issue, right? Because if we're moving into 2023 and they've said, okay, we're going to delay this requirement of time only, because they were going to implement time as the only way to code a split shared visit in 2023. They've said, well, we will delay that till 2024 because we're getting a lot of comments. I did see that the AMA and other specialties have submitted, communication that this is an issue and it's a problem. But CMS believes that time is the way to do this, and they believe that 50% of the time is the way to determine which provider should be billing for the service. However, we know that generally the NPPs do more of the time, but that does not account for the medical decision making, the knowledge base of the physician, and all of those things that the physician does kind of behind the scenes. Now, you can account for that time, even non-face-to-face time in these new split shared visit requirements. However, as we move to 2023 E&M guidelines, There are no history and exam requirements. There is no level of history or exam associated with the level of service billed. There's only medical decision making. So if the requirement is that one of three key components, history, exam, or medical decision making, must be met by the physician in order to bill under the physician, we only have medical decision making to bill unless they're asking us to use 1995 and 1997 guidelines to determine whether we should bill under the physician or not. That does not make sense. So I recommend communicating to CMS in the comments that we need a different method, because if the physician has to meet medical decision making in full for the level of service billed in order to bill under the physician, then the physician is documenting the entirety of the visit that would be technically required in order to bill level of service. And therefore, what is the purpose of split shared visits? It no longer matters. So one way to move the needle on this, because most likely your physicians will be focused on medical decision making. They will be communicating what diagnoses that they agree with, that the plan for these diagnoses and addressing the risk of the patient. If they're doing all of that, then they're likely meeting the medical decision making anyway. So maybe we just don't need these rules. Or if we do, we're just going to be basing this on the highest medical decision making that is documented, be it the NPP's documentation or the physician's documentation, and whoever documents the highest level of medical decision making gets the code. Now, the complexity here that of course, my teammates in our evaluation department are, trying to figure out, how do we chase this down? How do we compensate our physicians if the needle is going to move and the NPP is going to be billing for these services instead of the physicians? We have this back and forth shift that is happening. If you're paying your physicians on work RVUs and you're not keeping up with where those work RVUs are really going and where the physician work is really happening and what you could really pay for from a fair market value perspective, then you may be lost in your calculations and you may find a big slippage or change or, all of that. And so a lot of people are trying to say, okay, well, we're just going to pause. We're going to use this method or that method in order to overcome this. But I would communicate the implications of really shifting to time to CMS and what that would mean for your entity. Of course, we're only talking about Medicare specific claims. And so the Medicare claims would be at up to 15% decrease if you're billing under the NPP. And so what you have historically done, we've now increased the documentation requirements or the time requirements for the physician and getting paid less. So it doesn't add up, it doesn't make sense, and it's going to most likely cause a shift in care, which is not CMS's intent. So let's get back to the intent of trying to recognize a team-based approach and then start working from there to figure out how to compensate it. It makes sense that there might be a shift somewhere, but it doesn't make sense to this degree. So let's continue to communicate and analyze and communicate. You don't have much time, you have about a month, but do your analysis, determine what your shift would be if all of this was based on time, which would effectively be a majority of your services likely that would be billed under the NPP. And so that 15% shift would cause an additional shift in revenue loss to your hospital, to your practice, that was probably not intended by CMS. There we go. All right, so now we're going to talk about practice expense calculations and the Medicare Economic Index. This is another area where we want to make sure that this is not kind of flying under your radar. There are considerations being made kind of behind the scenes with CMS. The AMA is looking into this. AMA has hired an outside entity to look at how to potentially change how they're valuing the practice expense for the RVUs, because the way that it's been done historically often lags in time and is often focused on certain specialties, or how many responders that they have and all of that, and it creates issues with how things are valued, and they don't keep up with like current technology and current costs. Of course, we've had a huge shift in costs, and so all of that would have been valued previously would not be considered today. So how do we really shift this? How do we use certain instruments, certain surveys to gather the information? So I encourage you to look through all of these requests. You can see requests related to the difference between indirect practice expense, differences between facility and non-facility payments. You see various perspectives here, and it's important to comment on this because it could have a huge shift or create a huge shift in your practice expense RVUs, which could have a negative potentially adjustment to your practice expense needs. Sorry. So Medicare Economic Index is very similar. They're also looking to determine how to revise these weights. There's certain cost components that they're looking at, and the issue again is that the latest information is based on 2006 data. I mean, you're talking old. I mean, we certainly are not basing things, or shouldn't be basing things on something that old. So how do we keep things up to date? So CMS is proposing to use the Census Bureau survey information and then to supplement that from other sources when it doesn't provide the necessary detail. The concern here is that there could be substantial changes to the weights, to the point that there are increases or decreases in your non-physician compensation, your professional liability insurance, et cetera, that would cause a shift in your payment that would be sizable. So they've decided to not implement this in 2023 because of the significant impact of that, but they're requesting public comment. Now, with both of these areas, practice expense and the Medicare Economic Index, you would probably have maybe your financial teams or other kind of advocates or financial advocates that are looking at this and trying to determine the best way to calculate these things. Perhaps it's in your specialty society that they're looking at this. So try to be a part of this solution. Give information, respond to surveys so that your voice can be heard and you can be a part of that end result. In regards to behavioral health, so the behavioral health, of course, during COVID, we've seen a real hit to all of our friends, coworkers, family members in behavioral health sense. We were isolated. We've been, impacted by a pandemic. We've, had a lot of things going on in the news, and economic issues, et cetera, that have impacted behavioral health. And CMS is recognizing, and it's long recognized, that we need to come up with solutions to continue to expand coverage, expand access. So one of the ways that it's trying to do that is to permit the behavioral health services to be furnished by licensed professional counselors, marriage and family therapists, and other practitioners under general supervision versus direct supervision. So instead of having to have the psychologist at the location providing direct supervision, that general supervision would be allowed, so that rural areas or areas where you could get one of these professionals to serve the patients and may have concentrations of physicians in other areas, that you would be permitted to bill those services under a general supervision perspective. Also, they're looking to create a code set where you would be allowed to bill directly as a clinical psychologist or clinical social worker when providing a service as part of a primary care team. So they want this collaborative approach. They want the ability to say, okay, the primary care can kind of drive the care, and then we can have these practitioners billing for services that would increase the boots on the ground, allow us to really serve these patients more in volume. They are also requesting, CMS is also requesting the best way to cover care in the community setting versus the hospital, because sometimes a patient will just go to the hospital and they're flooding the EDs when really they would be best served in a community setting. So CMS is requesting, how do we do this? How do we create a structure to reimburse this in a way that would allow these patients, or really encourage the patients, to be seen in the best setting of care versus just this acute care setting. And then, of course, COVID has impacted our response to the opioid crisis. Whereas we're really trying to get our handle on things as before we went into COVID. As we got into COVID, things got worse. People have been isolated. Their ability to seek treatment has been impacted by that. So they're looking for really expanding the ability for patients to get to a provider, get to this opioid treatment program solution as much as possible. So one of the ways that they're doing that is to say, we will even pay in mobile unit scenarios, whether it's in a car or anything. We will allow you to bill no matter where you're at, basically, so that you can access those patients and they can access you. They're also looking to increase those payments. So if you're in this space, which I know a lot of you are, be sure to respond to their requests for comments so that you can have your voice heard in this area as well. So in regards to the global surgical package, this is a little curious to me, because I've heard CMS talking about this potential shift for years, probably about 5 years, that they've said, well, we're just going to go to zero global and not have any type of global package at all. And now they're asking for input. How are we going to bill? Because we believe as CMS that the number of global of the E&M services, basically, that are inside the global package are not actually done. Like, if there's 3 E&M services that are packaged in with this global service, that there may be only 1 done, or maybe there's none. And so how do we make sure that we're actually valuing this correctly and paying you appropriately? The options proposed are to revalue all 10 and 90-day global packages at one time, and perhaps with staggered implementation dates. Revaluing only the 10-day global packages, because it appears that the post-operative visit is really not occurring after these 10-day globals as much as they're valued to. The third option, revaluing the 10-day global and some of the 90-day globals that have a low post-operative visit recurrence. Fourth option, relying on the potentially misvalued code process to identify when those services are not actually performed. So it's really a bit in our hands to communicate what we think would be appropriate. But I have some ideas and thoughts on this, because what we see generally, and unless we really shift away from this concept of paying providers on work RVUs, you really need the data to be able to determine what provider did what. So oftentimes we are billing within our own system a dummy code or a non-billable code that communicates who did the service so that you can then compensate that provider. Why not say value the service based on the service, the surgical procedure or procedure itself, and allow the E&Ms to be billed again, or the 99024 for postoperative and have a value on it, a 99213 value on it. You know, why can't we just get to a component billing so that we're doing it internally? I'm seeing data all the time where you're capturing internal codes in order to determine, you know, who's doing what. So perhaps we just get to a point where we're showing, okay, this provider did this, and this provider did this, and this provider did this. And so then we are communicating in our billing what we're doing. I know that may increase some of your administrative burden, but I'm seeing enough in data that I don't know that it really would, because right now you're having to back out or calculate what, you know, who's doing what and how do you pay for this physician's, you know, service, how do you pay for this NPP service, et cetera, because fair market value is so tied to those personally performed services. So I think it's something to consider, but analyze this on your own, analyze the impact, and communicate what you think would be best. Dental and oral health services. Oftentimes, we're not communicating regarding dental services when it comes to the Medicare physician fee schedule, but this was something that they're requesting comment on. Mostly because there are dental services that often precede another medical service that are really necessary and need to be paid for and are appropriate to pay for to increase the success of the procedure itself. So CMS is asking, what do you recommend? What method should we use to identify when this is appropriate? And establish a process. How do we establish a process? What process should that be? They're looking for your comments here. So if you know of certain services that, you know, may be sticky on getting paid for and you're having issues because this patient, you know, whether the radiation treatment therapy, preceding a kidney transplant, there are certain services that need to occur to make sure that there's not additional infection for that patient, because infection can be deadly for that patient. And oral health is important to your cardiac and your other organ health. So it is important to communicate these if you're impacted by these at all. And maybe it would be transplant units, maybe it would be others that are dealing with oncology, that you would want to communicate what would be best to address this problem. Remember that you have until September 7th to comment on the proposed fee schedule, so that we are not negatively impacted by the fee schedule. They need your comments in order to understand the real context out here. Just don't take the rules as is. Communicate what that impact is. It's very important. And then, as I promised, we do have the resources at the end here that, let's see if I can pull that over. Well, there it goes. That will allow you to quickly link to the CMS guidelines, the fact sheets related to you know, what's going on with the fee schedule, specifics about behavioral health, and I've also included the AMA link for the E&M guidelines. Again, if you have any questions regarding the E&M guidelines, the 2023 guidelines, or the changes as it relates to CMS, the proposed rule, please include those in the chat or email us directly. We're happy to you know, gather that up and respond to you in regards to that. In addition, if you have a lot of E&M questions that you submit to me, then I'll probably do an FAQ session on the 2023 guidelines and maybe kind of incorporating the 2021 guidelines because they're really commingled now. So we'll pull this stuff together so that we can get this information out to you so that you can do a great job in implementing this in 2023. And let me get to this. So as a reminder, on August 10th, we have the 2023 Proposed Rule Part 3 session on the Quality Payment Program update. We also have on August 17th, the OPPS and ACS proposed rule. And then the IPPS, inpatient, and the rest of the nursing facility updates will be announced soon on when that will be, but keep an eye out on that. We have a lot of content to get through, but really appreciate your time today. Really appreciate you joining in. Glad to see so many of you live, and you know, by all means, contact us if you have any questions. We're very happy to help.